WebSurge is proud to present an exciting new learning platform. Are you finding it tough to track down reliable information for hernia surgery? Do you want to hear from world-leading experts in one simple, easy-to-navigate, unbiased and accredited place? Then welcome to Hernia Basecamp. Simple to navigate, you can watch videos, recorded webinars and conference lectures, all supported with suggested reading. It's a completely free of charge online resource for everyone with an interest in hernias. An educational program with 3 main aims, 8 chapters and the world's leading experts, with certification on completion. You can attend lectures, view videos or look up information, keeping you up to date with the latest views and technology via a user-friendly interactive platform. We're taking hernia care further together. So visit websurge.com and start your journey today.
A very good afternoon, everybody, and welcome. I'm very happy to announce that we have reached 11,000 followers on Hernia Basecamp. It's the number of people that are using this platform to improve the outcomes of their patients. And we keep speaking about making hernia surgery safer and better for everybody, both our patients, but also us. And I think you will not regret the next 60 minutes, which you will spend listening to some conversations, but also a lecture by one of the superstars of safety in hernia surgery. Thank you, Dominic, for joining us.
Thanks very much, Barbara. And can I add my thanks to Dominic for joining us too. Dominic is a very well-respected surgeon in the UK. He works in an intestinal failure unit in Manchester, one of the main units in the UK. And he probably sees more problems that other surgeons have created than any other surgeon put together, although he does own up to the fact that some of the problems he deals with, he's created himself. And I think that's where we're trying to focus in this webinar is not so much how to get out of problems, but better still, not to get into problems to start with. And in this topic around incisional hernia, we often fall into the trap of it's just a hernia. The world thinks that, our colleagues think that, but it's not really just a hernia. So Dominic, it's a privilege to have you. Look forward to hearing from you, and let's get your show on the road.
Thank you very much, Andrew and Barbara, for a very kind introduction. So what I'm going to try and do along the way with the help of Andrew and Barbara is to flesh out some ways that we might be able to prevent harm, stop things from going wrong, anticipate problems. And it's broken up into sections, and we really want participation from all of you watching this webinar. So please send in questions via the question and answer tab, and my co-chairs will do their very best to field the questions, and we'll try and get a conversation going virtually online. So we've used the term "it isn't just a hernia." And this picture here is a story that I know is repeated across many units in Europe and probably around the world, of somebody who was overweight and started with a primary 2-centimeter umbilical hernia, and 5 repairs later presents eventually at another hospital with a hernia this size, that had it been repaired properly first time round, would never have led to all these problems. And it's not just about the surgery, it's about the perioperative management of that patient as well. So when we're talking to patients about hernia surgery, I think all of us, myself included, sometimes we sort of forget that there are some truisms about hernia surgery, about how big the operation can be. And even in really good hands, there is a mortality associated with it. Every good surgeon around the world, if they have a decent series, will present mortality amongst patients having straightforward hernia surgery. And it isn't necessarily the operation itself, but it's the accumulation of complications post-operatively that ends up in the patient's life being put at risk. And so even with, you know, a good healthy patient to start with, there is at least a 0.2% mortality risk to discuss with that patient. Depending on how contaminated their wound is, it's possible to have a pretty significant wound event, be that a seroma, a wound infection, dehiscence. And I think, again, we'd rather gloss over the risk of surgical site infection, which is much higher than we perhaps give it credit for. Even in clean cases can be, you know, up at 10%, depending on what you're doing. We need to talk about chronic mesh infection to our patients, because whilst it's an uncommon event, when it happens, it's very, very serious in terms of trying to manage that problem. And something that we deal a lot with in my unit is the generation of fistulas at a later stage. And fistula and chronic mesh infection, one of the key features of those problems is that they present 2-3 years down the line. Often a chronically infected mesh that slowly erodes into the bowel, and then a fistula becomes apparent. So it pays to be suspicious of patients who aren't running a normal post-operative course, who have continued inability to heal their wound. Be suspicious that there may be a piece of bowel underneath all of that may be contributing to the problem. My personal series of incisional hernia repairs, about 15% of my patients complain of chronic pain. Usually it's better than the symptoms that they had from their original hernia, but again, it's more common than perhaps we give it credit for. And depending on the type of hernias that you're fixing, and you know how complicated they are, incisional hernia surgery still comes with quite a high recurrence rate. And again, my personal series, it's around 10%. On the other hand, when we talk to our patients, I think surgeons very much go on about the need for an operation. It's I mean, we're surgeons, we like to surge, but you know, we sometimes overplay that risk. And there's some large population studies, 3 of them actually, on patients who have been on a watch and wait protocol. And actually the risk of you strangulating an incisional hernia if you have no symptoms, if it's asymptomatic, is actually very, very small, somewhere between 3 and 4% risk over a 5-year period. So if you have a patient who has symptoms, who has pain, that's very different. But in someone who's asymptomatic, you shouldn't overplay the potential risk of strangulation. And it's very difficult when you have patients who present with pain to you as a reason for wanting hernia surgery, because often when you do that operation, you may not actually make that pain better. In fact, you may make it worse, particularly if they have chronic pain issues. There's obviously a benefit to someone's mobility and their core, and there's absolutely no argument that the cosmesis side, the aesthetic side of hernia surgery is important to patients. You know, we all come across patients who are unable to go out of the house because they actually feel very self-conscious about the size of their hernia. So those are good reasons to repair a hernia. And this study, if you haven't seen it, is a nice little demonstration of what happens if you don't get the repair right first time. So these are a cohort of patients, and they've looked at those that had primary ventral hernia repairs, and then their first incisional hernia, second incisional hernia repair, third incisional hernia repair. And you can see as you go across the group here that the risk of reoperation increases, the risk of surgical site infection increases, and the risk of a recurrent hernia increases for every continuous, what's the word? Sorry, for every attempt that you make to repair that hernia successive after the first. So it really pays to try and get it right first time.
Thanks, Dominic. But That's a useful introduction. Obviously, we will do our best to get informed consent, try and lay out what we can do and what we can't do in terms of repair, and it's trying to meet patient expectations. But it's very easy to say we should get it right first time. But what are for you the key steps of getting it right first time?
So I think first of all is trying to anticipate what you might encounter in the operating theatre. And as a trainee, I definitely remember operations where we came across something and the surgeon was surprised and in fact shouldn't have been. You know, with due diligence prior to surgery, you can anticipate an awful lot of things. I also think in hernia surgery, when you look back at operations that may not have gone to plan, the surgeons find themselves in a situation where they end up doing something that they weren't planning on doing because a good example is because they can't get the defect closed and they can't get fascial apposition. So they end up bridging the gap or putting two meshes in that are in contact with the bowel, and that leads to further problems. So and then finally there's what happens if the unexpected happens. If you have an intraoperative complication, what would you do in that situation? So we talk about taking a proper history, and I think in hernias, it's important to focus your history taking about some of the things that then determine the problems you might encounter. So I've mentioned already these significant to obstructive symptoms. That rather speeds up the anticipation of needing to operate on someone, because most hernias can be actually planned very carefully, but someone who's having obstructive symptoms, there's an urgency to get on with it. Very important to assess the big three comorbidities, which are active tobacco smoking, obesity, and diabetes, particularly poorly controlled diabetes. Important to work out what might have happened before. So when somebody says to you that they've had a previous hernia repair, you want to try and work out if they've got mesh and where it might be in relation to the previous surgery that they've had. You want to know if they've got an active wound infection or if they've had a history, or particularly of a resistant organism like MRSA in the past. And you want to know about stomas that are present and any that they may have had in the past, because they may have more than one hernia, one at the stoma site and one in the midline. And it's useful to have some idea of GI anatomy, particularly if somebody, say, had a reversal or a Roux-en-Y or an anastomosis that you may encounter that you need to understand and appreciate what you're looking at. So the significance of all these things, as I've already said, is that the risk of incarceration is small, that smoking increases the odds ratio of every single complication after ventral hernia repair, that a BMI of greater than 30 kilograms per meter squared increases your risks of both wound complications and recurrence. And the other things that I've mentioned on the left-hand side help you start to think about what you may encounter in the middle of the operation that might put you out of focus from the hernia repair. And I mean, this is an old photo in our hospital because we have an electronic record now. But often, if you're dealing with patients that have come from another hospital, it's still important to get hold of old paper notes and to have a look through, particularly operation notes, because we all use these terms like anterior component separation or Reeves stopper repair. And often what you actually then surmise from what's happened to the patient or from their imaging in terms of a CT scan is that it may not fit with what you thought was a Reeves stopper repair, that in fact the mesh may not have been put in the plane that you thought it might be, or they may have just had a myofascial release and not had a full anterior component separation. So assessing alongside a good quality CT scan that's been done in the last year or so helps you to understand exactly what the new anatomy looks like. And that helps you to appreciate complexities, including things like bowel that's pressed up against mesh that may actually be firmly adherent to it. And that helps you also think about other adjuncts that might be required or techniques that might be required to enable you to repair that hernia properly first time round. And we talk a lot about having a plan A, B, and C. So a good example is, say you have a patient who has had an IPOM, laparoscopic IPOM repair of an incisional hernia, and they have tacks that have been used to hold the mesh in place, and you are considering, and the hernia's recurred, and you're considering their surgery, and you're thinking of doing a posterior component separation. Well, that may be very difficult to do if the tacks have caused lots of scarring in the retromuscular plane. And it may be intraoperatively that your plan B would be to change to an anterior component separation. So that's an example of thinking how you might do an operation more than one way. And if you look at their CT scan in advance and you come across either a very wide midline defect or carbonyl ratio of less than 2:1, which is the width of the rectus muscles added together being less than twice the width, then you need to think about adjuncts or other things that will allow you to achieve fascial apposition. So just simple weight loss itself will reduce the volume of the hernia. 5 kilo weight loss in patients has been shown in CT scans to significantly reduce the volume of the hernia and increase the chances of you getting everything back together. I'm aware that to our listeners, not everybody has access to Botox, but if you do have access to Botox to inject into the abdominal wall, it can give you 5 centimeters at the midline and can help you to actually bring the fascia back together. And as already explained on the last slide, you need to start thinking about what techniques are going to be suitable for the problem in front of you. And it may be that you still can't get anything together despite doing all those things. You might need to resect something, like, for instance, increase the reduce the abdominal content.
So, sorry. I was just writing down some notes. So you're basically saying that there is not enough planning ever, and you shouldn't really trust your colleagues or, in fact, anybody. And you should always anticipate any kind of problems that you can run to, even those you can't really think about before.
No, I think you must put words in my mouth, Barbara. I think it's important to try and understand what went on before, because if you take everything as read, that somebody has had, what I would consider a reef stopper repair, that actually you may find when it comes to the operation, it's actually that isn't what's happened. It helps you to understand why why the hernia occurred, or why the patient has had a complexity. And what I'm saying is that you're not going to be able to anticipate absolutely everything, but you can usually get an idea from reviewing everything that's been done to that patient. So how their anatomy has changed as a result of previous surgery, and what you have in front of you in terms of up-to-date imaging. You can usually work out roughly what you're going to find at the time of the operation. And I think when I said earlier that I've been present at operations where surgeons have found things that they were unexpected, is because the patient hadn't had up-to-date imaging, for instance. Does that make sense?
Yeah, it does. So just trying to wrap up a little bit. Yeah.
So finally, just a quick thing about Botox, if you have access to it. So in hernias that are the midline, a midline incisional hernia, where the defect width is between 10 and 17 centimeters, if you use Botox, you may actually be able to downstage what was a bigger operation, like a component separation, to a straightforward reef stopper. So that's one of its great benefits. In studies, it's been shown to increase fascial closure rates, and this is beyond this talk, but if you were to use preoperative progressive pneumoperitoneum, then it reduces the chance of you ending up having to bridge a wide defect, because basically it gives you a lot more stretch of the muscles and they come back together.
Yeah, thanks, Dominic, on that introduction to getting it right first time. Now, Do you have red lines? Do you have cutoffs? Do you say you don't operate above a certain BMI? Do you not operate on smokers? Or is it trying to tailor it to everyone? So you might have a young person who's a BMI 40 but has never smoked and is not diabetic. You might be more likely to take them on than someone who has smoked, has poorly controlled diabetes, and is actually not overweight.
That's a good question. It's a conversation, isn't it? I always have a conversation with all my patients. I do feel that smoking is a red line, because the evidence presented by the World Health Organization in 2021 about not only about the risks to somebody undergoing elective surgery, but also the fact that if you can give up smoking tobacco for just 4 weeks, your risks of complications come down significantly. And if you can stay off tobacco for 6 weeks, then your risk is the same as a non-smoker. So that, I don't think that's a big amount to ask somebody. And the benefit to them is that it significantly reduced their risks. BMI is much more difficult, isn't it? I'd start by saying that if you're going to ask, I ask everyone to see if they can lose some weight for me, because of what I said earlier about reducing the volume of the hernia. But if it's somebody whose body mass index is above 35, then I think it's important that it's supported weight management. Certainly as a trainee, I was exposed to patients who were told to go away, lose weight and come back, but with no support to that patient whatsoever, no dietitian advice, no weight management clinic advice, and certainly no bariatric surgery. And that's not fair on anybody.
Do you set targets, and how do you work with those targets? Do you have staff that phone the patients up and see how they're getting on and sort of keep cajoling them to keep going?
Yeah, I do. So I have a hernia advice leaflet that is a Word template that I can tailor to any patient at the end of our conversation in clinic, and I send it out to them. And in that, in the document, I actually put their intended weight loss target, and I base that on a discussion with the patient. So if they've always been a big person, it's unrealistic to expect them to to halve their weight, isn't it? So I actually ask them things like, what was what's a weight you think you can achieve, or what weight have you got to in the last sort of 5 years, and actually agree a target with them that they think that they can get. And I have the benefit of a weight management clinic, which is run by 2 endocrinologists who I can refer to, and they have dietitians involved as well. And then and then I say 2 things to them: that firstly, I'll be back in contact with them within 3 months, and if or whatever time frame they think it will take for them to lose that weight. But also I say to the weight management clinic, if the patients get anywhere within their intended target, just close to their intended target, to let me know, and I'll listen for surgery, assuming there's no other health issues.
We have a question, Dominic, and that's about loss of domain and bowel prep. I know there's some work that's demonstrated bowel prep seems to increase wound events, but what's your view on bowel prep?
I should say I'm a colorectal surgeon by trade. I actually bowel prep people very infrequently. I suppose it's a good question, because I suppose if you're really up against it and you are really concerned about the potential for closing a very big defect with lots of loss of domain, then bowel prep is probably going to be of a benefit, because you reduce the size of the guts in simple terms. So I don't have I don't not believe in it, but I very rarely use it, I would say.
But the reduction in size is just very temporary, isn't it?
Precisely, yeah. I mean,
so we've got our patient worked up. We're ready to go. We're surgeons. We're desperate to get in there. We're talking about incisional hernias. So someone's been there already, maybe several times, either due to the pathology or previous repairs. So the bowel might be stuck. It's at risk of making holes. Tell us a little bit about enterotomies, how to avoid them, and what they mean.
Okay. So in this section here, we're just going to talk a little bit about the significance of an enterotomy, which I think, again, we often downplay. you can anticipate that that may happen if patients have had multiple. The more laparotomies you've had, the higher the chance of adhesions and the risk of enterotomy. And I think there are a few things that are really sort of simple. The first is to allow enough time for that operation. So somebody who's a reoperative surgery, complex hernia, I would allow most of an operating list, if not all of an operating list, for that one patient. Depends how complicated it is. And in our unit, when we anticipate things are going to be difficult, we share it with a colleague, because that helps to take a lot of the pressure off, which is another feature of how these things go wrong. If you weren't aware of the significance of an enterotomy, this data here from the large American College of Surgeons database, NSQIP, was given to me by Todd Henneford. But basically, what it shows is that if you cause an inadvertent enterotomy at the time of hernia surgery and you put permanent synthetic mesh into that wound, that you are increasing the risk of a mesh infection or a hernia recurrence by a factor of 10. And that is a very significant increase in risk. So the first message, I think, is if you cause an enterotomy, and it happens, then the first thing to do is to think again about, do you continue along the same operative pathway? And the description that I often give is, if a pilot takes off from an airport and a bird strike takes out one of their engines, they're not going to carry on flying to their destination. They're going to land, turn around, get to safety. And we should be the same. It doesn't necessarily mean that you can't fix that hernia, but the first question is stop, and should you continue the operation as you planned it? Should you use permanent synthetic mesh, or should you think of doing something different? And if there's lots of enterotomies and the bowel is very badly damaged, then a very safe strategy is to exteriorize the most proximal enterotomy, rather than relying on 6 or 7 repairs, suture lines to hold underneath your hernia repair. So I'm just going to talk through a few things that we do in our unit. This is being passed on through 5 generations of surgeons about ways of safely opening a reoperative abdomen. And technique is really a very big part of it. So the first thing to do is to get into an abdomen in the safest place. So if the midline scar doesn't run all the way to the top or the bottom, then you're best starting in a part where there is no scarring, because underneath there's less chance of there being bowel stuck there. If somebody already has a full midline scar, then the safest place is to get in the epigastrium over the liver, because you're less likely to encounter loops of bowel up there. And then a lot of enterotomies are caused by traction, either traction as you open the abdomen or traction through scissors. So it's important to pick up the sheath with toothed forceps, such as Cocker's clamps, and then your assistant provides appropriate traction upwards, and you put traction, as you can see, the gloved fingers there over a swab at right angles, and then very carefully dissect the bowel away from the midline, traveling laterally. And there will come a point, however terrible the adhesions are, there will come a point where you encounter where the peritoneal cavity reestablishes itself and it becomes easier. You just have to carefully open the space up on each side. And then what you want to do is gradually extend the wound, but do it under direct vision. So I have seen people who put a finger underneath and think, oh, there's nothing there, and open the abdomen on their finger and gone straight through a loop of bowel, because small bowel stuck underneath a midline wound can be feel deceptively normal. So you need to actually lift up with your Cocker clamps and look down the length of the midline scar and open it under direct vision. And the same is true for when you get down to the pelvis. The bladder can be stuck up in the same way. So again, just need to look very carefully. I'm just going to show you a very quick video here. This is knife adhesiolysis, which may appear a bit counterintuitive, but this is a way of carefully dissecting bowel away that is actually much safer than scissor dissection. So for very, very stuck loops of bowel, using a knife and the heel of the knife in gentle brush strokes like this helps to separate the bowel away, and then pinching it helps to establish the gap between the peritoneal fold that you can see on the right hand side there and the loop of small bowel. It's a very, very safe way of dissecting free. You're very unlikely to cause an enterotomy if you dissect that way, because you're not causing traction. If you encounter really bad adhesions, particularly like on the left-hand side here, stuck to a piece of mesh, then rather than continue to try and divide those adhesions from the front, turn the bowel round and have a look at it from the back. You can see on the right-hand side there, much simpler adhesions. Again, if you start dividing those, you can actually thin out everything until you just get to the back of the piece of mesh, and then it's easier to remove that. And again, if you've got a plate of mesh, as you can see in this picture here, then using the scalpel to carefully dissect the loops of bowel off the back of the mesh is a really good way of doing it. And if you can see bits of mesentery, start over that, because dissecting over fat's much safer than dissecting over serosa. And if it's really, really stuck and there's no way of finding a plane, then you may need to leave small swatches of mesh attached to the bowel. That might be the only safe way of getting through that. If you do your adhesiolysis, check when you've done that there are no serosal injuries, and if there are, then repair every single one that you find. We use 4OPDS interrupted sutures, and the reason for doing this is that some serosal injuries give way in the post-operative period to form a full thickness enterotomy. And as in this situation, if you've had a very, very complex, long dissection, lots of bowel that you've had to free up, and you've resected a piece of bowel, or you have a stoma, then you can use a Foley catheter and dilute methylene blue. So you get a vial of methylene blue and dilute it in a litre of saline. And you can inject that into the bowel, and it's incredibly useful for telling you about occult serosal injury that you haven't seen. It glows up as a dark blue blush, or even worst case scenario, an enterotomy that's gone unrecognised. And you should do that and then follow it all the way along and repair every single serosal injury that you see.
So enterotomy is always a significant event, and it should never be overlooked and never taken lightly. I think although it happens in the theatre, it doesn't necessarily stay in the theatre with the patient. Another thing is, which struck me, is that probably hernia surgery should be reserved to only very calm and patient surgeons. The technique is the key, and also I think the assistance is very important, because you can do your job if your assistant is half asleep or not really helping you. So I think this is something which maybe wasn't highlighted, but I think it's very, very important to have somebody who's helping you actively during the operation.
Actually, Barbara, that's absolutely right. The assistant needs to be able to move when you're not dissecting, but then keep absolutely still, displaying the anatomy for you, particularly when you're doing adhesiolysis, so that you can then safely divide those adhesions, because if they move suddenly, you may inadvertently damage a piece of bowel. So that's a very good point. And
intraoperative decision making is always a challenge. You know, you've geared up a patient, you've set them aside for the whole day, you've chatted to them about the ins and outs of surgery, and then within the first hour you've made an enterotomy. That's a very difficult time for a surgeon to start making sensible decisions, because you're thinking about the patient, you're thinking about the wasted theatre time of abandoning a procedure. But can you help me and the audience? What are your sort of red lines for stopping an operation? You know, is it the number of holes, the degree of contamination out of one hole? Is it colon versus small bowel? Give us a feel of when we should abandon an operation because we've done too much to the bowel.
That's a very good question, Andrew. It's very difficult to sort of give a black and white answer to this, isn't it? Because because there's lots to it, and it depends a lot on the patient. But I think the most important thing to say is, if you do something unexpected, if you make an inadvertent enterotomy, stop for a minute and actually just consider what you're going to do next. If that's occurred in a piece of bowel that's really firmly stuck, I mean, the worst enterotomies are those that occur in a knot of bowel that's firmly stuck down in the pelvis that you haven't managed to liberate. Then I would have in terms of what you're thinking is next, is should you call a friend to come and have a look? And often that's a really good thing to do, because they don't have the same emotional investment in the patient as you have, and they haven't caused the enterotomy, which tends to cloud your judgment, only because people want to do the best for their patients, but they're often not thinking straight when something like that happens. So if it's a straightforward enterotomy, minimal contamination, and you've managed to free everything else up, or you think you can easily free things up, then that doesn't necessarily mean you should truncate the procedure. In those sort of situations, then it may be perfectly reasonable to repair the enterotomy and to continue. I think if you're getting into the stage of having to resect bowel as a result of it being damaged, I think that's where you really need to think very carefully about, firstly, do you continue as planned, and secondly, are you going to put particularly any form of permanent mesh into the wound because of the risk of
often when it comes to adhesiolysis, we obviously take the bowel off the anti-abdominal wall so we can get movement and repair it, but often we wouldn't, unless there was a history of obstruction, worry too much about the intraloop adhesions. When you do cause an enterotomy, do you take more care to do intraloop adhesiolysis to make sure there's no potential for distal obstruction, or you just keep your fingers crossed?
No, yeah, no. If that had happened, I would free all the adhesions from the DJ flexure all the way to the ileocecal valve, for exactly that reason, Andrew. That if something already has gone wrong, you've repaired it. What you can't afford is for that repair to give way because there's potential for distal obstruction. I think going back to the start of what you're saying, if the patient, I mean, this is the weird thing about adhesions, isn't it? You can have an entire abdomen full of adhesions, but the patient has no obstructive symptoms at all. If that's the case, then really all you need to do is just release the adhesions that are stuck to the anterior abdominal wall that are going to prevent you from doing hernia repair. You don't need to start dissecting every single loop free. But if there's a history suggestive of obstructive symptoms that isn't really explained by the hernia itself, or you have an enterotomy, then yes, I would free everything up.
So we've got the message on enterotomy. We can prevent many of them, and then if we do cause them, it's probably useful to phone a friend. But what else can we do intraoperatively to try and get this right, Dominic?
So I think firstly, we need to think very carefully about mesh position, and this is more about trying to prevent any mesh. It doesn't really matter what it's made of, becoming involved in underlying bowel, and specifically if you've had to make a suture line, or if there's an old anastomosis or whatever, you don't want any of that getting anywhere near your mesh because of the risk of it breaking down or causing a mesh infection. So I think in terms of a counsel of perfection, you really want to avoid inlay suturing mesh to either side of the defect, because it usually fails, because the biomechanics of that are such that the mesh won't stay where you put it. Again, I've never really understood onlay mesh, particularly for large hernial defects, because of two problems. One is the onlay is on the low pressure side of the hernia, and one of the Reeve stopper principles is to use the force that created the hernia to repair it, which is meaning putting the mesh on the high pressure side. But also you're putting mesh underneath the skin with the potential for it to become exposed if the wound breaks down and for it to become infected. So the best planes in terms of any repair is the retromuscular or the extraperitoneal plane. And whichever of those you use, what you want is a complete layer of something beneath your mesh to prevent the bowel from sticking to it. So that's usually provided by an intact layer of peritoneum, but not always. And that posterior layer can be buttressed by the bladder down in the lower part of the wound, by omentum, by the falciform ligament, by hernia sac. So really important not to resect the hernia sac away at the beginning of the procedure, but instead just to divide the middle of the hernia sac and try and preserve it until such time as you've worked out what you can get together behind the mesh. I think although people have described using dissolvable synthetic meshes behind a permanent synthetic, my concern about that is just that you still need an intact posterior layer, because bowel will still stick even to a dissolvable biosynthetic. And I think you should really try and avoid intraperitoneal meshes, particularly for, I mean, we're talking mainly about open surgery here. So I think an open IPOM is not an operation that has much merit in my mind when you can develop an open operation, a retromuscular plane. Obviously, it's important to keep mesh away from all bowel because of the risk of fistulation, and also because of the way that intraperitoneal meshes of whatever description generate a vascular reaction from the bowel, and the angiogenesis that forms sticks the bowel firmly onto the mesh, and in some situations actually makes it very, very difficult for you to find a plane of dissection between the two when you come back to do another operation of any description. And inlay or bridging should be avoided if possible, because of the very high failure rate that it gets to. Now, if you have a big hernia practice and you encounter lots of big hernias, there are times where you are never going to get the fascia together. But in general, for a modest incisional hernia defect, a 10cm width defect in the midline, you really should be able to get the fascia together. And the reason for doing that is because if you don't, then in these studies, the increased risk of recurrence is significant, over 5.5 times. It doubles the complication rate, and the time to recurrence is 9 times shorter than if you had managed to get full fascial apposition. And bridging itself is an independent risk factor for recurrence. So those are some of the things that we can do. I've said about preserving the sac, and some of you may be familiar with a technique called a peritoneal flap herniaplasty, which actually uses the sac as part of the repair. But you can also augment your posterior component separation or your anterior component separation by preserving the sac and using it to cover the mesh in the midline. And the most important part of it is, as you develop your retromuscular plane, that one part of the sac is kept attached to the anterior layer and one to the posterior layer. So you've got 2 flaps that can come together over the top of the mesh. And that's been shown in posterior component separations as well to reduce the risk of surgical site occurrence and recurrence of the hernia.
I think it's really nice that you have officially declassified the peritoneal sac repair as bridging. So I think Andrew might be very happy that this was mentioned, that peritoneal sac repair is not bridging. So I think it's obvious bridging is bad and we want to avoid it, but sometimes people just don't know any other how to do it. So I think it comes back nicely to the original idea that before you do something, you have to educate yourself and learn how to do things and have your plan A, B, C, D, and whatever else you may need. The retromuscular plane seems to be the holy grail of the abdominal wall reconstruction, if it's still available. You have mentioned cases that have had 5, 6, 7 goes before, and sometimes this plane just does not exist anymore. And then would you revert to preperitoneal plane, or what would be your next most logical? Probably.
Yeah, so, well, I was taught how to do reef stopper repairs by accessing the preperitoneal plane. And I suppose the reason that we don't do it routinely is because it's very easy to make holes in the peritoneal layer.
Yeah.
But, you know, because it can be very difficult to dissect that layer, particularly if there's scarring and old stomas and so on. But yeah, I mean, I think being able to dissect that plane is a very useful way of overcoming that problem if somebody's had lots of repairs. It comes back also, Barbara, to what I said before. If you have all the old op notes and you look through, you may just be okay in that one of the planes may be preserved, or alternatively, you may be, I mean, a good example is people who've supposedly had an anterior component separation, but actually just had a myofascial release. On at least 3 occasions, I've gone back into one of those abdomens and I've just released the plane between the external oblique and the internal oblique more, and I managed to get midline closure. So sometimes it's just sort of looking at the op notes and trying to work out what was done in relation to what you see in front of you.
Definitely. And I think, and something that you have mentioned again several times before, the bowel is something that we don't want to touch ideally at all, and ideally if our mesh doesn't touch it either. So I know we're not talking about IPOM, but definitely an open IPOM is not a logical operation to do.
I guess you mentioned onlay, and I agree, I rarely do an onlay now, but there are times occasionally where, particularly sort of perhaps little old ladies, where I've started to develop the retrorectus space, and I've been thinking, well, both the anterior and posterior sheath are very thin, and individually they're very thin. And sometimes it's been my plan C, a bailout opportunity. And then the other danger around that is trying to avoid bridging. But if you're not so good at component separation, is it worth the danger of transecting the whole of the abdominal wall by mistake to prevent bridging? Or is it better to bridge, accept the recurrence, and let someone repair it another time?
Okay, so 2 questions there. Yeah, I mean, there are no absolutes in this, are there, really? I think we should anticipate not using onlay mesh, for the reasons that I've said. And also, I mean, the other thing we haven't mentioned about the retromuscular plane is that it appears both in some animal studies and in human studies that the retromuscular plane we are able to clear bacteria from that plane, and actually the chances of getting a chronic mesh infection if we use that plane are less. Plus, any mesh, irrespective of what it's made of, benefits from being sandwiched between 2 vascular layers, and the retromuscular plane is just that. So, or the extraperitoneal plane. So those are the reasons why I feel very strongly that you should try and use that plane. But there are no absolutes. So I agree with you, Andrew. There may be an occasion where an onlay mesh is a sensible thing to do. In which case, I think you need to be able to quilt the mesh to reduce the risk of the mesh coming away, and also the risk of seroma. And you need to be confident that you've got decent tissue that you can bring together over the top, which to take your example, a frail, thin, elderly lady may not actually have very good quality tissue to put over the top. So, you have to sort of think.
There's a balance.
Would you consider like contamination during an operation an indication not to open the retromuscular space? If you have decided to change your plan, you have had too much contamination, you just want to close the bowel and close the belly and put something over the top, would that be sort of alternative option for you?
So no, absolutely, Barbara, because the trouble is it's a big space to open, and if you've got contamination, it will get into that space. I mean, I'll be honest, in that situation, I think I'd probably not want to put anything permanent in, and may even, I mean, once you've violated the retrorectus plane, you're not going to get back in it easily. So I know what you're getting at is, should you put something in there because you've opened the plane up? I think yes, but I would go for something that is not permanent.
No, I meant if you didn't open it at all. You're trying to get into the abdomen. You haven't opened it yet. Would you go to onlay?
I would sort of think about actually
a suture repair, just closing it.
Come back another time to do the repair properly. Yeah, I mean, because the potential for mesh infection is far too high, and the likelihood is that the whole repair will fall apart if so why violate a plane if there's lots of contamination? Why violate a plane that is going to likely cause you trouble? well, patient trouble particularly.
So the quick questions, Dominic. One is, obviously, you'll be many times you'll come across patients who already have mesh in them. It could be retromuscular, it could be intraperitoneal. If that mesh is quite firmly attached to the patient in area, will you keep that as part of your either anterior or posterior layer?
Yeah, good question. So firstly, it depends whether it's infected or not. If it's not infected and it's fully incorporated, yes, I would leave it in place. And something that I remember you saying, actually, Andrew, if it's permanent synthetic mesh, remember it doesn't really heal very well once you've cut it. So you're better off suturing it closed with something like choline sutures rather than dissolvable suture because of the risk of the mesh coming apart. If it's infected, then that's much more difficult. Infected mesh, really, you should remove every last little bit of it. But the reality is that some of the mesh tends to be incorporated. The bit that's infected tends to be the bit that's loose, that's easily removed. And removing every last bit of mesh may actually cause more trauma to the, to the muscle layers and to the posterior erector sheath than leaving it intact. So I think you have to sort of take a view, but if it's infected, you really want to try and get rid of everything without causing too much trauma to the remaining tissue.
Been there, unfortunately.
There is a question, Dominic, and I presume you've got lots of funny stories you could tell us, things that you've seen that you wish perhaps you hadn't or done differently.
Well, so I you prefaced the beginning of the introduction about that all of us have complications, myself included. So it's not that the last thing I'd ever want is for people to think that sort of smirking at their mistake, because it could have been mine. But I think you when you see things, you get a sort of theme for why things went wrong. The same sort of things tend to happen. And so I know there's a lot of text here, but if you just read through this is a real referral letter. And I put it up just because you can sort of see how it encompasses a lot of things that I've been talking about. So you've got somebody who's got lots of adhesions. This was in a recurrent hernia in somebody who'd had an anterior component separation with no mesh. And the transverse colon was stuck firmly to the back of the abdominal wall skin where the hernia had recurred. And in the process of freeing that, they not only made a hole in the small bowel, but they also damaged the large bowel in the process as well. So they then went on to do a small bowel resection. And then they also thought it was safe to do a transverse colon resection. So now this patient has two staple lines, a small bowel resection and a large bowel resection. And then despite all of that happening, they continued to consider a hernia repair. And because of the patient having had a previous anterior component separation, they decided to put an onlay proline mesh over the top of everything. And in fact, they didn't actually get the middle together. So the mesh was in fact sat over the bowel with just a vicryl mesh underneath it. And this comes back to what I said earlier about if you can't get a decent posterior layer beneath your mesh, don't rely on another mesh to act as a barrier between the bowel and adhesions. And that patient went on to develop a permanent problem with their wound. So if you have a look there, you can see several things. You can see up here the edges of trimmed mesh. So this is proline mesh. This is a 4-year-old wound that still hadn't healed. And right in the center here is a colocutaneous fistula. And because it was from the end of where the staples have been cross-stapled across the side-to-side anastomosis, it was very low volume, but it was enough to lead to this chronic mesh infection and a chronic discharge. So that could have all been avoided had the mesh not been put over the top, if perhaps they'd anticipated how difficult it was going to be beforehand. And I think if that would be me, I would have stopped after doing the bowel anastomosis rather than certainly putting permanent synthetic mesh over the top.
Yeah, I think your analogy is very good. An aircraft on takeoff that loses an engine, you don't keep going. And we have surgeons are bad. We have it in the aviation industry too. We call it press-onitis. And once you've started, you've got to keep going. And it's almost as if stopping is admitting our own failure when actually it's the right thing to do for the patient. But I think the messages are coming out clear. We have to make the right decision with patients, get their informed consent, get them on board, make sure they're as fit as they can be, do their operation properly and carefully, minimizing enterotomies. But there are times when we do all of those things and things still don't go right, and then we have a patient a few days post-op or a week or so that's deteriorating. Any thoughts around the management of such patients?
Yeah, so I think the first thing I would say is we tend to, when we have things like seroma or hematoma, we tend to try and manage them conservatively often, because particularly if you've done a complex repair, the thought of taking that patient back to theatre and potentially disrupting that repair it seems worse than maybe doing something active. But in this picture here, which is, you can see a large infected seroma and a piece of mesh that's actually bowing inwards under the weight of that seroma. The right thing to do is to drain that fully, and the best way of doing that is actually in the operating theatre. And to wash all of that out, and you can still leave the mesh intact. There's a good literature behind applying VAC to these kind of wounds, and actually that allows the ingrowth of tissue, granulation tissue through the mesh, and actually can heal the wound quite quickly and clear the infection that's there. Sometimes the seroma may be small enough to benefit from a radiological drain, but this clearly would not be. And hematomas, again, I think you need to think about active management of those sometimes, particularly if they're large, because there may be ongoing bleeding within them. A CT scan, CT angiogram will tell you that. But also because of the dense nature of the hematoma, it's not going to clear. It's going to take weeks to clear, and the risk of it getting infected is very high. So have a low threshold for actually getting back in if you have to, because long term it will save you from problems.
Yeah, I think we do have a reticence sometimes to go back to theatre for obvious reasons. We're worried about perhaps their anterior closure was a bit tenuous. We don't want to disrupt that. But I think being a bit more active, you're right, hematomas, even if there's no extravasation of contrast on the CT, on the arterial phase, they probably are better washed out. What would you do, obviously with a hematoma, and it's maybe day 2, day 3, would you leave the mesh in? And then the same question, we're now in this situation where an infected seroma, would you try and preserve the mesh, or do you think it's kind of doomed to failure?
No, I think, as I said, there's a literature behind salvaging mesh through the use of VAC. So I would firstly just want to reassure myself that there's nothing else feeding the bleeding and or contamination. Make sure there's no, just be confident that no stitch lines given way on the bowel or anything like that. But as long as it's just a hematoma or a seroma that's become infected even, then washing all of that out adequately and leaving the mesh in place is not the wrong thing to do. And you may want to combine that with VAC, as I say.
I'm actually very happy you say that, because a lot of surgeons tend to go back and rip everything out. Yet the same surgeons might happily continue after enterotomy. So I think a lot of our decision making in the theaters is not based on facts. We often act based on our emotions, which is not the best thing for our patients. And I think it's great that seminars like this bring some light to these topics. And thank you very much, Dominic, for updating our knowledge on this, because you are, unlike us, working in a department which deals mainly with disasters that all the rest of the world is trying to avoid. So you're the person to go to person if you get into trouble, and somebody who definitely can give the best advice on how to avoid these situations and how to get out of them. So I have learned a lot tonight, and thank you very much for this.
A real masterclass, Dominic. We knew it was going to be. We didn't tell you the questions in advance. I saw you squirm a few times, but I thought your answers too were superb. And we all have at different levels of experience, and we can all learn. And I've learned again this evening. So thank you very much for your input. Obviously, thanks to my co-host, Barbara, who was the brains behind Hernia Basecamp. I was just her secretary. They helped her along the way. Can I promote again Hernia Basecamp to you all? Tell your friends, join up. Anything that you think is wrong in Basecamp, let us know. If there's lectures missing and you're happy to provide them, we're absolutely delighted. And please use it to tell all your friends. Barbara, Dominic, thank you very much.
Thank you.
WebSurge is proud to present an exciting new learning platform. Are you finding it tough to track down reliable information for hernia surgery? Do you want to hear from world-leading experts in one simple, easy-to-navigate, unbiased and accredited place? Then welcome to Hernia Basecamp. Simple to navigate, you can watch videos, recorded webinars and conference lectures, all supported with suggested reading. It's a completely free of charge online resource for everyone with an interest in hernias. An educational program with 3 main aims, 8 chapters, and the world's leading experts, with certification on completion. You can attend lectures, view videos, or look up information, keeping you up to date with the latest views and technology via a user-friendly, interactive platform. We're taking hernia care further together. So visit websurge.com and start your journey today.